Welcome, everyone. Today's webinar is titled FDA Drug Topics, an update on transmucosal, buprenorphine, and dental caries. My name is Dr. Kara Burke, a pharmacist and team leader in the Division of Drug Information. I would like to welcome you to this educational activity sponsored by the FDA Center for Drug Evaluation and Research, Office of Communications, Division of Drug Information. We thank you and appreciate your patience as we continue to offer these CE courses completely virtual. If you experience any technical difficulties, please email us at ddiwebinars@fda.hhs.gov for direct assistance. Before I introduce our speaker, I have a few housekeeping remarks. All faculty are expected to use generic names. If trade names are used, those of several companies should be used rather than only that of a single supporting company. Unapproved use disclosure. CE faculty and speakers are required to disclose to the attendees when products or procedures being discussed are off-label, unlabeled, or not FDA approved, and any limitations on the information that is presented. Disclosure. The faculty's planning committee members and the FDA CE consultation and accreditation team have nothing to disclose. We hope you will enjoy meeting our presenter today. Commander Mark Liberatore is a pharmacist officer in the United States Public Health Service Commission Corps and serves as the Deputy Director for Safety in the Division of Anesthesiology, Addiction Medicine, and Pain Medicine at FDA's Center for Drug Evaluation and Research. With more than 13 years at FDA, Commander Liberatore has directed many large post-approval safety activities on opioids, treatments for opioid use disorder, non-opioid analgesics, and anesthetics, and he is the division subject matter expert on post-market drug regulation. Commander Liberatore earned his Doctor of Pharmacy, PharmD, in 2003 from Duquesne University in Pittsburgh, Pennsylvania, obtained his Regulatory Affairs certification from the Regulatory Affairs Professional Society in 2017, and is currently studying to achieve a Master of Public Health degree from The Ohio State University. Now, please give a warm online welcome to Commander Liberatore.
Thank you, Kara. Good afternoon, everybody. As Kara said, I'm Commander Mark Liberatore. I'm a pharmacist officer in the Public Health Service. And as she also said, I'm the Deputy Director for Safety here in the Division of Anesthesiology, Addiction Medicine, and Pain Medicine. It's a real honor for me to present to you today some information, and this is about an action that we took regarding transmucosal buprenorphine and dental caries. I'm really humbled by how many people have joined this CE activity. I want to thank Kara and a lot of others who have set this up. There's a lot that goes on behind the scenes leading up to one of these events, and I want to make sure everyone's aware that this is really a team effort. That said, I'm going to be the main speaker today. I'm going to do the whole presentation. That is until we get to the Q&A panel at the end. I do really try to be an engaging public speaker. If you've got feedback from me, I would gladly welcome it. When you go to claim the CE that Kara was talking about, there's going to be a survey, and I'll ask that you take a few minutes to fill that out. I'm always looking to get better at this. So with that, here are the learning objectives for today, and pardon me from more or less reading directly from the slide, but starting from the top, we're going to discuss the national opioid crisis, opioid use disorder, and available treatments. By the end of this, CE should be able to describe cases of dental caries with the use of transmucosal buprenorphine containing products. We're going to review FDA's framework for updating product labeling, and I'll explain FDA's findings and the resulting regulatory action. And finally, we'll summarize how healthcare providers can help mitigate these adverse events. Okay, so in order to touch on all of those objectives, here's the general outline of what I'm going to go over. You're going to get some info on the current state of the opioid crisis and opioid use disorder. We're then going to get into the safety signal and the evaluation itself. I'll shift gears a little bit, give you some insight to how we here at FDA consider the evidence in the context of our regulatory authorities. I'll then describe the action we took, the communication plan that went with the action, and some of the follow-up to the action. I'll give a quick summary. That's just one slide, I think, at the end. There's going to be 5 challenge questions for you. And then we're going to have this Q&A discussion at the end that'll include myself along with 3 subject matter experts from different fields here at FDA. So as you're listening, please think of some questions you might have for the end. It's not necessary to type them in during the presentation. I'm not going to be stopping the talk to answer in real time. So if you want to just write them down, have them ready for the end. If I don't cover it in the topic, if I don't cover the topic in the talk, then I'll try to get to it at the end. So let's get started. So the first topic, the opioid crisis and opioid use disorder. So the first line here on this slide might surprise you, and that's because, the opioid crisis, as we know, it's been going on for decades, but it was only declared a public health emergency in 2017. And you're going to hear me use the word crisis. If you watch the news, read articles about this topic, you will often hear to it referred to as the opioid epidemic. I prefer using crisis. I feel that epidemic is more closely associated with infectious disease, but really they're synonymous. Regardless of crisis or epidemic, these are more umbrella terms that cover many aspects. For instance, you might go to a lecture and you hear about the addiction crisis or the overdose crisis. And these are obviously related, but they are somewhat different. Opioid crisis or opioid epidemic covers pretty much all the components you see here on this slide. But next, I want to just highlight for you how many people are affected by this crisis. And I know since I wrote these slides, there is some more up-to-date information out there, but we're going to go back to 2022 when this action took place, and we saw well over 100,000 drug overdose deaths in this country. If you calculate that out, that's about 30 deaths per 100,000 people. You adjust that rate over the preceding 20 years, you can see it's about a fourfold increase in deaths. The graph here, and there's one more on the next page, they might look familiar to you if you've taken any CE on opioids in the past. And I know it's a little small, but the point here is to show that the increase in deaths is definitely, there's definitely an increase over the last 20 years. And if you notice, and I just eyeball this over the last maybe 4 or 6 years or so, the problem has indeed gotten worse. I am not really going to go into or comment on the effects that the COVID pandemic may have had on the rate of drug overdose deaths. That's probably a lecture entirely on its own. The point here I really want to make is that this is a public health crisis, and the trend line is going in the general wrong direction. I try to cram a lot of information on this slide. I want to draw your attention to that green line. And if you can't differentiate the colors, it's the line in the graph that shows this sharp increase over the last 10 years. That line represents synthetic opioids other than methadone. So what we're talking about here is fentanyl and its analogs. So yeah, tramadol is an opioid. It would be included in this group, but that's not really the point here. The point is that in recent years, the opioid crisis, and in particular, death due to opioids, is being driven largely by fentanyl and fentanyl analogs. Now, I want to be super clear about this. It doesn't mean that prescription opioids, prescription drugs in general, heroin, other opioids are no longer a problem. That's not true, and pardon the double negative, but those drugs are still indeed problematic when it comes to overdose-involved deaths. But you can see from some of the rates that I list by date here on the left, deaths due to these other products are steady or maybe even trending down a little bit. But when you look at the number of deaths due to fentanyl over the last 20, and then go back 10 years up through maybe 2022, you can see that when people talk about the fentanyl crisis, that indeed is a real thing. There's a lot to unpack here. And again, I could probably have a whole CE just on the crisis and opioid use disorder, but for the purpose of this talk, I just wanted you to have the background so you have a basic handle on the crisis before we get into the treatments and then ultimately the safety signal that you're here to learn about. Okay, one more slide, my background. These 11 lines list the DSM-5 criteria for opioid use disorder, and you can see in this box here that I've inserted, the severity of OUD is based on how many of these criteria apply to patients. So, for instance, a patient that takes more opioid than they're supposed to, that's criteria 1, and then maybe spends a lot of time trying to obtain that opioid, that's on line 3. Those just fitting just those 2 criteria, that patient would have mild OUD. Now, take that same patient and they start missing work, that's line 5, maybe missing family events, line 7. And then this continued behavior happens despite these problems, that's line 6. So that's 5 criteria that would put the patient, say, in moderate category. Again, I'm just trying to give this audience a flavor for what OUD looks like in the setting of the opioid crisis. I really am grateful. We've got so many people who've joined, but it occurred to me when writing these slides that I see these kind of data every day, and I'm familiar with these criteria, but others might not be. So again, hopefully you find this helpful. Okay, so moving on, the good news in all of this is that there are treatments available for OUD. There's plenty of studies out there that show that MOUD, and that's medication for opioid use disorder, has been shown to decrease opioid-related mortality. And when I want to mention that Health and Human Services, our parent department, and I think all of us here at FDA would agree that evidence-based treatment is indeed a pillar of the overdose prevention framework. There are 3 FDA-approved medicines used to treat OUD. Naltrexone, which is often given in a depot form every 30 days. I'll quickly plug that there was a webinar just like this one last year about this time on injectable naltrexone. If you want to learn more about that one, you can access that CE through the DDI webinar page. But moving forward, methadone, many of you have probably heard of that. Methadone clinics have been around for a lot of years, and for a long time, it was the only MOUD option for many people. One note, though, again, methadone can't be dispensed from a pharmacy for the purposes of treating OUD. To treat OUD, methadone has to be distributed via clinic. And that's what sets apart the last drug on the list, buprenorphine, which is what we're going to dive into more next here. Briefly, I just want to mention buprenorphine. It's been around for quite a while. It was approved back in '82 for pain, but 20 years later in 2002, it was approved as a treatment for OUD, and it could be written by prescribers and dispensed out of pharmacies. Buprenorphine is, but not always, found in combination with naloxone. It's available commonly as a sublingual tablet and film. I'm going to introduce a new acronym for the purpose of this CE. We're going to use TMB to describe transmucosal forms of buprenorphine. Buprenorphine, however, is also approved as an extended release injection. There's also a sub-Q implant. The injection is becoming more and more common. The implant is not currently manufactured, I don't think. There's also a patch or transdermal system approved for pain, and there's a sublingual film that's approved for pain as well. The dosing for those indications is very different. For instance, dosing for pain is in the micrograms, where dosing for OUD is in the milligram range. Buprenorphine's got a somewhat unique mechanism of action among opioids, and just to be clear, if you're not familiar, it is an opioid. It's a partial agonist at the mu receptor, but it's an antagonist at kappa, and it's this unique receptor activity that's thought to make it effective at treating OUD. One more thing before we leave this slide, we're in sort of what we call a new era of OUD treatment. So some of you might be familiar with the Drug Addiction Treatment Act of 2000, used to be known as DATA 2000. And that was a program where special training was required to prescribe for buprenorphine. But as of June 2023, all DEA registered prescribers of controlled substances must now complete 8 hours of training on MOUD. And this will allow you then to automatically, upon DEA license renewal, be able to prescribe buprenorphine in an outpatient setting. And the thought behind this is that this will greatly increase the number of possible prescribers and in turn, hopefully increase access. So DATA 2000 is no more. Okay, so next section. I'm going to shift gears a little bit and get into what I'll call the bulk of the presentation about TMBs and dental caries. I'm going to start by going all the way back to the origins of this safety signal. So the signal actually came to our attention back in the summer of 2018 when our pharmacovigilance team, who evaluates post-market safety signals, they became concerned about a particular report of dental caries in a patient that was taking sublingual buprenorphine. The team then went ahead and performed this disproportionality analysis, and they found that buprenorphine-containing products were disproportionately higher for reports of dental caries. And so at this point, OSC, which is our Office of Surveillance and Epidemiology, opened up what we call a track safety issue. We know those today as newly identified safety signals, or NISS, and an investigation was started. I want to just take a minute, though, and show you some images of exactly how these products are used. These are examples taken directly from labeling, one of the sublingual products in particular, but tablets can be used in the same way. At the top in the yellow box and the yellow highlights, you can see how and where these products are used sublingually. On the bottom in the blue, these are images and explanations of how to use the product buccally. And the point I want to literally illustrate here is that either application, the product is really close proximity to the teeth. And I want you to keep this in mind as I continue, because this becomes a rather important point, as you might imagine. I also want to make the point that these products, they have to be dissolved in the transmucosal space. So PO, or per oral, or swallowing whole, is not an approved route of administration. There would be a substantial difference in absorption if you take it orally, making the drug more or less ineffective if you go by that route. So I want to emphasize that the drug must be taken transmucosally. All right, so back to the investigation. DPV, again, Division of Pharmacovigilance, found nearly 500 reports in the FDA Adverse Event Reporting System. We call that FAERS, and another dozen or so from medical literature. So they applied this inclusion-exclusion criteria, and 305 cases were selected and reviewed. Treatment for dental caries was described in just over half of the cases. And most often the treatment involved tooth extraction, which was documented in about a quarter of all reported cases. Notably, a large portion of the cases were reported by providers. And these reports had extensive documentation with really good descriptions of the temporal relationship between the start of the TMB therapy and dental caries. We often get reports with really sparse information or information that's incomplete or just simply not helpful. And that was not the case here. Some cases, again, can't even be analyzed, but here we had really good reports. We saw many of the reports were very thorough, robust, had really descriptive accounts of the situation. And I can tell you that the quality of the reports was definitely a factor in our decision making. One more point you might already be thinking is that, well, these patients are on TMB because they're being treated for OUD. Are people with OUD known to have dental problems? And I'll say that, yes, there are reports that substance use disorders do increase major oral health problems, but many of the cases reviewed were really explicit about the patient having little to no dental issues prior to starting TMB therapy. So for instance, I'm going to share with you a few examples. Here's a case. This is a 30-year-old male who was on the combination TMB product, 8 milligram twice a day. It was treated for OUD. Past medical history provider remarked that the OUD was from oral pain meds. So we're talking, whole pills. And he had, quote, impeccable teeth, wasn't on any other medication. After starting TMB therapy, after 1 year, the patient had 15 caries. And this is one where we know the patient had dental work, and it was noted that despite these caries, the TMB treatment was indeed continued. Here's another case, 25-year-old female. Again, this is a person got the combo product for OUD. The mom was quoted as saying that her daughter's teeth were in, quote, perfect condition. Now, unfortunately, this person had a more severe form of decay, and after approximately 18 months, her teeth began to rapidly deteriorate. And unfortunately, for this person, within 3 years, had to have all teeth removed. So again, perfect teeth, began treatment with a TMB, 3 years later, all teeth removed. So now we're going to dive a bit deeper into the review itself, get into some of the details. So of the cases reviewed, they were quite evenly split by gender. There was a wide age range. The mean and median were closer to middle age. A little over 20% of the cases were reported by providers. Again, robust case descriptions. You could see a lot of the other numbers here. So for instance, 113 cases involved 2 or more teeth. And I want to say, this could have been anywhere from 2 teeth to all teeth. Some reports gave the actual numbers. You already heard of at least one case where 15 teeth were documented, another where all were documented. We had good information on formulation. We had good information on the indication, and both formulation and indication were key factors in decision-making. And I'm going to get into that more later on in the slides here. But you can see there was a range in time to diagnosis, but the median and mean show most cases were reported having occurred between 2 and about 2.5 years. Let's go over a few more cases that I think characterize this adverse event quite well. Here you've got a 53-year-old male, sublingual film. Did have a little bit of history here, including chronic pain, but no reported history of dental caries. After initiating therapy, this gentleman experienced 15 caries inside a 2-year period. He was seeing a dentist every 3 months and was diagnosed with caries at each 6-month visit while on TMB. Here's another example. This one, 34-year-old female. She was taking the single ingredient Buprenorphine sublingual product. This report, again, from a healthcare provider, remarked that she experienced, quote, deterioration of tooth enamel and significant damage to the teeth in the region of product dissolution. So what the provider is telling us here is that she's having dental problems, and she's having them right where the product is being applied. She did have a history of substance use disorder and treatment. including methadone treatment program. When she was in the program, she was having regular checkups and had them before going on buprenorphine. At that time, her teeth were in good condition. When she moved to buprenorphine, she had a toothache, and that's what brought her to the dentist. When she goes to the dentist, the provider noted that all front teeth needed fillings, and this is right in the region where the TMB was being used. And here's a paper on the subject by Suzuki and colleagues. The mean age in this research was found about the same as the cases reported in FAERS. The time to onset of the adverse event was a bit longer, almost 4 years in these cases. The authors did take note of the drug, the dose, the regimen, and interestingly enough, the time to complete dissolution, which they found to be almost 9 minutes in this study. As you can see, the average number of caries was around 5, and the majority of patients reported tooth pain. That was the event that brought them to the dentist, where the signal, this adverse event, was ultimately discovered. So speaking of dissolution time, we took note of the product labeling in various drugs for the subclass, and we went through it and looked. And one of the products in their studies, it took up to 30 minutes to completely dissolve. Another product tested dissolution with different temperatures of liquid. In all cases, it took around 4 minutes. The other products are sort of in between those two bounds, and it's a little all over the place. We see 17 minutes, 8 minutes for 2 different doses for one product. Another product states that it will take at least 7 minutes. And finally, in a comparison of 2 products, we see a range of 5 to 12 minutes. I think the bottom line here is to show that it does take some time. Yes, some longer than others, but it does take some time to dissolve the product. And all the while, the product is in that oral mucosa, often right up against the teeth. And so why does this matter? Well, caries can occur from activity of acids on the tooth, and normal pH of the saliva is somewhere between 6.4 and 7.4. But when the pH drops below 5.5, you can see enamel start to erode. And I'll just sort of ask this in general. You don't have to type it in or anything, but just think to yourselves, any guesses of the pH on buprenorphine, what the pH of buprenorphine is? So buprenorphine has a pH of 3.5 to 5.5. So you start to put this all together, prolonged exposure due to long dissolution times, plus that exposure is in this acidic environment. Those factors might be expected to contribute to these adverse events. All right, so hopefully the picture is starting to become a bit clearer. But then we have the question of what should be done with this information, what can be done with this information. And so next, I'm going to give you some insight as to FDA's regulatory framework, and then I'm going to go ahead and describe the action that we took. So we're going to go back almost 2 decades and talk about the Food and Drug Administration Amendments Act of 2007. When I started at FDA in 2011, this was still kind of new, but many years have passed since this act was passed in September 2007, and FDA, as we call it, amended the Food, Drug, and Cosmetic Act. And there were many changes, but the part we're going to talk about next is the authority to require safety labeling changes, especially in the first and third sub-bullets here, which show we can require these changes for both brand and generic drugs. So this is a rather important slide for understanding the safety labeling change process. FDA can make changes to labeling when we become aware of what is called new safety information that we believe should be included in labeling. But this term, new safety information, and we've got an acronym for everything, we call this NSI. So NSI, this term is key. What does NSI mean? NSI, it's got somewhat of a broad definition, though the information we use, it's got to be scientific material such as reports, studies, literature, etc. And I've already mentioned we had a lot of reports from FAERS. We had a lot of study data from medical literature. We have this, we feel is a strong biological plausibility. In other words, what I'm telling you here is for this action, we considered the body of evidence, not just a single case or single study. Though technically we could take action on a single adverse event report. I'm just going to say, though, that did not happen here. There was a lot of research that went into this, a lot of cases analyzed with a lot of other data. But if we are thinking that the body of data requires us to make this change in labeling, what kind of changes can be made and what else must we consider when we are looking to make a change. So first, let me talk about the type of changes that can take place in labeling. This is a screenshot showing a template of the highlights section of labeling. These sections are in what we call physician's labeling rule or PLR format. Most FDA approved labels are in this format, and I think all new drugs approved by FDA have labeling in this format. I think most of you are probably familiar with what's called a box warning, and I'll make up just a quick footnote here. It's called a box warning. You'll hear black box warning or black box. It's actually the regulatory term is just box warning. But I want to draw your attention to some of the other key sections we consider when we think about labeling changes. The authority under FDA that I previously described, it allows us to make changes in any section, but the sections in the red boxes are what are most commonly changed. This includes not just the box warning, but the contraindications, the warnings and precautions section, adverse reactions, and also drug interactions. We can also change or require a new medication guide. The med guide, that's the document that's written in that patient-friendly language. You often get this at a pharmacy when you pick up your prescription, but in this case, we considered adding in a new warning and precautions statement, and as well as some other changes. And in the upcoming slides, I'm going to explain why we landed on a change in that section. And to do that, I want to first explain what kind of issue might go into a warnings and precautions section. So a warning, I'm going to use the shorthand, a warning is intended to identify or describe adverse events and other safety issues that are serious or otherwise clinically significant. And you can see I've added emphasis to the serious and otherwise clinically significant. And on the next slide, I'm going to go over what that means, but that's only half the story. A warning's also got to be based not just on the seriousness of the issue, but on the causal association. So in order to add an adverse event to the warnings and precautions section, there should be reasonable evidence of a causal association. I do want to remark, it's really important to understand that that causal relationship doesn't need to be definitively established. It needs to be reasonable evidence of a causal association. And I want to say, I don't take any of this lightly. I think adding a warning to labeling is a big deal. But if there is reasonable evidence and you have a serious adverse event, then it should be in the warnings and precautions section of labeling. So as promised earlier, I want to quickly go over what it means to be serious or otherwise clinically significant. And I know this slide's got a lot of words on it. On the left, you can see the descriptions of what's defined as serious. I think if you look at the cases of dental caries that we saw, there's probably already an argument there that these cases are indeed serious because they disrupted these normal life functions. But if, let's just say you weren't willing to buy that argument, let's look at what is defined as otherwise clinically significant. So you can see that the seriousness relative to disease, incidence rate, that can all be considered. We have this category of other that speaks more to the consideration of patient management. So for instance, something that is clinically significant can be clinically significant if there's a serious outcome unless the regimen is adjusted, if patient selection would have an effect on the likelihood that, let's say, that patient would or wouldn't experience the adverse event. That could also be considered clinically significant. But I want to highlight the last sub-bullet, which says that an adverse reaction that affects patient compliance, particularly when non-compliance has potentially serious consequences, that can also be considered otherwise clinically significant. And so with respect to the treatment of opioid use disorder, I really agreed with sort of this thinking, the way this is laid out. Buprenorphine for OUD has been shown to significantly improve treatment outcomes. And if someone were to stop their treatment due to this adverse event, it would likely increase their chances of experiencing a fatal overdose. So I really have no doubt that these dental caries, if not serious, are certainly clinically significant. And to kind of bring that point home, I want to share with you one last case report. This is a 36-year-old female. You kind of know this story by now. Patient had rapid tooth loss over 14 months while on TMB. Brittle teeth, but the x-rays prior to the therapy starting, showed zero damage. Reason I'm showing you this one, though, is because of the clinical significance. So this patient said she would hide her teeth when talking. So this clearly affected this poor person's life, but here is even more important part in my mind. She stopped taking the treatment for OUD because of these events. And this is certainly something that we do not want to see. And if it can be mitigated in some way, we would want to inform prescribers of that. All right, so we covered the clinical significance of this issue, but remember, I said that's only half the story. The other half is whether there's this reasonable evidence of causal association. The guidance for industry on this provides a really nice list of factors. I'm displaying that on the left. This isn't an exhaustive list, but we can consider other factors. But for the purpose of this CE, I'm going to quickly walk through the 7. So number 1, frequency. Again, hundreds of cases we had. Number 2 didn't really apply, that factor about placebo rate, not in this circumstance. Number 3, dose response relationship. I'll say possibly. I'll say also that most of the cases were perhaps more closely tied to dosing frequency, not the milligram dose. Pharmacology, I went over what was appeared to us at least to be a strong biological plausibility given the pH issue. Temporal association, number 5. In this case, the event, it's not immediate. It wasn't as though this is like an IV drug where you give the drug and 30 seconds later something happens. It wasn't, as though you give the drug and a minute later a tooth falls out. But there was really reliable information on the dental health prior to treatment in many of these instances. So I'm going to say this was a yes for me. Number 6, the G challenge, re-challenge. I don't think it really applied in the cases reviewed because the outcome was more definitive. In other words, you can't unhave that cavity. You can't unhave that serious dental adverse event. And in almost all cases where the person did stop buprenorphine, we don't really have good information on what the next course of treatment was or patient follow-up with the dental health after stopping the TMB. And finally, number 7, whether the adverse event was known to be caused by related drugs. I have here both a yes and a no, and I got an entire slide to explain this one a bit more. So I have to say, given the totality of evidence, I was already convinced that this was an AE that needed to be in the warnings and precautions, but I got to say, this is what really put this over the top for me. So we asked ourselves, were there cases of dental caries with other sublingual transmucosal forms of opioids? The answer is yes, but they were very few. Also, the events they associated with these other opioids, they were already labeled and they were attributed to the composition of the formulation, specifically, in most cases, higher sugar content. And that was not the case with TMB. But when you look at the 305 cases involving transmucosal buprenorphine, 28 of them implicated a brand name product that was indicated for pain. So why is this important? Well, there's only one TMB product that has the indication for pain. And it's worth mentioning that the dosing is like 10-fold less than the OUD indication. So if you take the 28 over 305, that means almost 10% of the cases were in patients being treated for pain, taking far lower doses. So is it the drug or is it the dosage form? Well, let's look at both. There were 0 cases for patients being treated for OUD using buprenorphine depot. And there were 0 cases for patients being treated for pain using transdermal buprenorphine. So let me put this together and say this another way. We don't have any cases of caries in OUD patients taking a different form of buprenorphine. We don't have any cases of caries in pain patients taking a different form of buprenorphine, but we have hundreds of cases of patients taking transmucosal buprenorphine for either OUD or pain. So this is kind of a summary slide for this section of the talk. We found cases of dental caries to be serious, otherwise clinically significant. The evidence of this drug in dosage form was determined to have a reasonable causal association. The information has clinical implications, I think, certainly, including prescribing decisions and patient management decisions. And as I mentioned, we determined that a new warnings and precautions statement needed to be added. So we're getting there. I'll go over the action and labeling next. So I'm not going to spend a lot of time here. You've seen the evidence. I've talked about it. I just want to mention that what I listed in the regulatory letter is listed here, 305 cases, rampant caries, tooth extraction. I will say too, in the letter to the companies, we did acknowledge and reference the idea that substance use disorders can cause caries, but we went on to mention that in many cases, these events occurred in people with 0 prior history of problems. Also, in many cases, occurred in people that were taking TMB for pain and didn't have a diagnosed substance use disorder. And so here it is. This is the language that now appears in labeling. I have this on 2 slides. There's 2 parts. This is part 1. Here we describe the adverse events, and by now you've heard about these: rampant caries, teeth falling out. We also mentioned again that many of these cases occurred in people without any prior history of problems. The second paragraph informs the prescriber what they should do about it. So I'm going to take a little bit more time here. So first, let me click. As a prescriber of these products, you should refer your patient to a dentist for regular checkups. Secondly, you want to educate your patients on how to improve their oral health while taking TMB. And we suggest next here that a reasonable strategy is gently rinsing the teeth and gums with water and then swallowing. And then finally, avoid brushing immediately. Wait at least 1 hour after taking the product before brushing teeth. And we think this is to prevent, we feel that this is the right advice to give, to prevent mechanical damage to the enamel. And this will allow, this length of time will allow the pH of the oral cavity to normalize again. This information is reiterated in section 2.5 of labeling under method of administration. Here we inform prescribers of the same strategy: rinse with water, avoid brushing for at least 1 hour. I want to point out the cross references to other sections in labeling. They contain more information. And so we try and do this to point you as the healthcare provider to different sections that might have more information. So let's say you just go to section 2 here and you're looking for this dosage and administration information. You might see that there's a warning on this and it points you to section 5, and then you can go to section 5 for more information there. We also have this listed in the post-market experience section, and also an information for patients is in 17 in the med guide. And I haven't talked about 17 yet. I didn't put it on the list before, but this again, called the information for patient section. What it really is a section to help the provider provide counseling to the patient. It contains what we feel is the most important information that needs to be conveyed. Generally speaking, it doesn't contain any new safety information that isn't already elsewhere in labeling. So if you were to read the whole label, you would already know this information. But if you just wanted to simply search exactly for what you should tell your patient, 17 is really where it's at. You can see here, we put the same advice that already appears in the warnings and precautions section. You want to advise on proper hygiene. That's that swish and swallow part. Take that sip of water, swish and swallow. Refrain from brushing for at least 1 hour. And then finally, encourage your patients to have regular dental checkups and tell their dentist they've started treatment on TMB. Finally, medication guide. And if you're not familiar, this is the document that's created in that patient-friendly language. It's intended to be read directly by the patient. So this is that one that you often get it at pharmacies. Sometimes it's stapled to the bag when you pick up a prescription. So for my fellow pharmacists and technicians that are out there in the audience, this is a plug to always draw that attention to that medication guide. A lot of thought, a lot of work goes into writing these. And in this particular case, I would say you want to direct patients to the how I should take the trade name section, and you see the 2 new bullets here that speak to this new warning that we put in. Okay, so now we're at the last subsection of the talk, and then we're going to get to the Q&A panel. So I appreciate you sticking with me thus far. I want to talk about the communication plan. FDA's got a number of tools available to disseminate information. In this case, we issued, get ready for it, another acronym, DSC, Drug Safety Communication, providing information to both patients and healthcare providers about the labeling change. And really, just for the sake of time, I'm not going to go through the content of the DSC. I do want to point out that there's just a ton of information that goes into these. A lot of credit goes to the folks in our Office of Communications. They're experts in writing these. And you might be able to see there's a lot of drop downs here, anywhere from what is the concern, give me the bottom line, to what are you announcing, all the way to additional information for healthcare professionals. And because this is a CE, and many, if not all of you, are healthcare professionals, I just want to mention it's in this subsection, you're going to find more of the detail of the cases and what FDA considered. And this goes hand in hand with the data summary, and that's going to give you even more information, sometimes even the actual case level information that was relied upon for the new safety information that went into this. So this is what FDA put out. How was this received by other organizations, you might ask? Well, for the most part, it was picked up quite a bit, both in the lay press and online medical publications. At the top here is a headline from the Journal of the American Dental Association. You can see here Medscape, American Journal of Nursing, Reuters, At the bottom is the American Pharmacists Association. I will mention that there was some negative reaction. We did get a few questions, had to answer a few inquiries on the heels of this announcement. But again, for the most part, the action was well received and re-announced through many professional societies. So you may have seen this through your association's journals, and we're really grateful for that. So this is what again, the associations and the press said. What do you think the patient said? Well, before I click here, I just want to say this is one of my favorite slides in the deck, and it's not necessarily because of the colorful language or the fact that many of these folks had to go through this adverse event, but it's my favorite because it's really candid. And at the end of the day, we're here trying to protect public health, and you can see by these comments, this was indeed a public health issue. This was an issue for a lot of people. A lot of people had, strong, beautiful teeth, and then, were on this and then experienced this and didn't have an explanation as to why. But I'll point out at the bottom, this last comment here in green that said that shedding light on this and putting it in labeling was a good thing. And there's more. There's at least 2 studies I'm aware of that reference this action and study this effect further. So the first study by Minian et al. Found that there was an increase in dental adverse events with TMB as compared to the transdermal version. These are findings very similar to what we found in our review leading up to this action. Remember, we did not find any cases of dental caries associated with transdermal buprenorphine. This study looked a little bit more closely at the acidic nature of the product and also implicated the pH as having a role, again, something we feel was a contributor. The second study by Barris and colleagues concluded that sublingual or buccal buprenorphine might increase dental adverse events, but the risk of that should not have an effect on the benefits of the products. And we certainly agree. This speaks to the important point I made earlier that these products are effective, safe and effective in treating OUD, and it could be very dangerous for somebody to discontinue therapy. So even though this adverse event is real, is problematic, mitigation is key because these products remain an important option in treating addiction. With that, we've made it to the end of the lecture portion of the talk. I want to thank you for sticking with me this afternoon. I want to quickly summarize. So number 1, we're still in an opioid crisis in this country. Treatments are available. You learned about a safety signal that was detected. That's number 2. Let me click here. We worked that up, and you learned about how the review team approached that data. We also covered FDA's regulatory authority, including how we go about changing labeling in the post-market setting, how this led to the decision to add a new warnings of precaution statement. And finally, and if there's one takeaway from today here, it's this number 4. Even if you don't remember all the details of the CE program, I hope you will now at least know that these events can occur with these products, and you know what advice to give to your patients. So we're running a little short on time. I'm going to quickly introduce my colleagues as part of the Q&A panel. I think we get time to squeeze in a few questions. And I'm really grateful that these 3 individuals are here. Dr. Samantha Cotter is a safety evaluator in the Division of Pharmacovigilance, and that's in the Office of Surveillance and Epidemiology. Dr. Cotter is the individual who first detected this signal, and she did a tremendous amount of work on this issue leading up to this action. She deserves so much of the credit for what was done leading up to this. I want to thank her for her support in this activity as well. And Sam, welcome. Thank you again, really, truly, for being here. Dr. Monisha Billings is a dental officer and epidemiologist who works in the immediate office of the Office of New Drugs. There, Dr. Billings is a clinical team lead for the Safety Policy Research and Initiatives Group. Dr. Billings was instrumental in helping really connect the dots with this issue, especially as it related to the possible mechanisms of action and how to mitigate these adverse events. I want to thank Dr. Billings for her work on the safety issue as well, and welcome her to this discussion. Monisha, we're really grateful to have you here, and again, welcome. And finally, Dr. Zach Illig is a medical officer who works in the same division as I do. That's the Division of Anesthesiology, Addiction Medicine, and Pain Medicine. Dr. Illig is a trained medical toxicologist, has experience in prescribing TMB in hundreds of patients. Zach was not part of the original action. He wasn't yet here at FDA, but he brings his clinical expertise to our addiction team. And I'm grateful that he's agreed to participate today to perhaps answer some of the clinical questions. I've gotten to know Zach more over these past few months, working on a number of issues, and I'm really grateful for him to be here today. So Dr. Illig, Zach, welcome, sir. Thank you for being here. And then quickly, finally, as Deputy Director for Safety, I can also participate and help answer any regulatory questions that may come up. So, Kara, with that, I think we now turn it to you.
Yes, thank you so much, Commander Liberatore. That was a great presentation. And this does conclude the presentation portion of our webinar. This is to Monisha. What is the logic behind waiting to brush teeth?
Thanks, Mark. Thanks, Tara. Thanks, Mark. So I saw several questions in the chat box as well about this concept. So for the non-dentist, dental enamel primarily consists of hydroxyapatite crystals, the calcium phosphate and the hydroxyl ions, right? And so any acidic product can etch the enamel surface, and this can happen within very short periods of time, including just seconds. And these acids can dissolve these hydroxyapatite crystals, knocking off the hydroxyl and the phosphate ions. So on top of this action, this acidic action, where the teeth become so soft with the dissolution of the hydroxyapatite crystals, when you top toothbrushing on top of that, you're subjecting an already compromised, weakened tooth structure to mechanical wear. And as Mark, Dr. Liberatore talked about, the pH of buprenorphine hydrochloride is 3.5 to 5.5. So the hypothesis here is that the oral pH falls well below the critical pH of 5.5, while this buprenorphine, transmucosal buprenorphine, is dissolving in the mouth for about 15 to 20 minutes. And studies have shown with every drop in the oral pH, there's a tenfold increase in the solubility of the hydroxyapatite crystals. So the rationale here is by waiting for that at least 1 hour after using transmucosal buprenorphine products before brushing one's teeth, that allows time for the oral environment to recover, for the normal resting pH to resume with the help of the salivary buffering capacity. So that is why we had issued in the DSC to, take a sip of water, swish, swallow, wait for at least 1 hour before brushing one's teeth to mitigate the damage from the teeth, from buprenorphine.
Thank you so much, Monisha. All right, the second question coming in. Some of these cases sounded almost unbelievable. Did people really lose that many teeth in that short amount of time? And I think this is best addressed by Sam.
Hey, Kara, thank you. Hi, everyone. So my name is Samantha Cotter. I'm from the Division of Pharmacovigilance in the Office of Surveillance and Epidemiology. Before I answer the question, I just want to say that I am one of many FDA employees working every day to monitor these products throughout their life cycle. And during the monitoring process, safety evaluators may come across a safety signal like Mark has presented today. This was the case with buprenorphine and the dental adverse events. At the time, it was my responsibility to monitor buprenorphine. And when we first came across the signal, I approached it as we do with other safety signals. We reviewed the FDA Adverse Event Reporting System database, the published medical literature. We also reviewed similar medications and data mining, medications that are used in opioid use disorder, pain disorder, other opioid medications, and other formulations. We came across social media posts and continued looking at the signal, and we found biologic plausibility. We found that in the cases, exactly what you're asking, young individuals with a mean age of 42 years experiencing multiple dental caries, tooth fractures, tooth loss with extensive dental adverse events, including numerous teeth and rampant decay. The cases that Mark presented today were not unique. There were many other cases that were similar to those ones, and patients would describe that they're losing all their teeth, they're losing their upper teeth, all the teeth were involved. We did our best to exclude reports that had confounders, including illicit substances like methamphetamine and crack cocaine. However, many of these patients, as Mark said, had a past medical history documenting good oral health. And as some of our cases, we looked at other medications for opioid use disorder. Patients had been on products like methadone without problems in the past. And then when they started the TMB, that's when the issues showed up. Also, the location in the mouth was interesting. We expect adverse events in the back of the teeth, but we were seeing events occurring in things like the front of the teeth, the incisors, and the canines. So before I turn it back to Kara, I just want to make sure that I communicate to everyone online that FDA relies upon you, and those reports that were turned in by the general public and healthcare providers were instrumental in helping us to work up this safety signal. And we would like people to still continue to support the FDA MedWatch program by submitting these adverse event reports.
Thank you so much, Sam. Let's squeeze in one more question. The question that came in, wouldn't the depot forms of buprenorphine be safer? And I think this is a best fit for
Probably
Zach.
for Zach. Yeah, I think Zach could take that one. Yeah.
Sure, you bet. That's a great question. And thanks to everybody who's able to stick around, even though we're a couple minutes over. I'll keep my response brief. But I think it's important to highlight that all buprenorphine containing products, regardless of the dosage form, carry with them the possibility of an adverse reaction. And while it's true that we didn't see evidence of depot buprenorphine causing dental caries, the depot forms of buprenorphine can cause adverse reactions that are not normally seen with transmucosal buprenorphine. For example, depot buprenorphine may cause injection site reactions. With transmucosal buprenorphine, there's no injection, so of course there's no possibility of an injection site reaction. I think what's really important to highlight is that treatment needs to be tailored to each individual patient's needs. And while depot forms of buprenorphine may be the preferable treatment option for some patients, for various reasons, they may not be preferable for other patients. So we really hope that increasing the awareness of dental caries associated with transmucosal buprenorphine empowers both patients and prescribers with the knowledge needed to mitigate the effects that transmucosal buprenorphine may have on dental health, so that patients can continue these effective medications for the treatment of their opioid use disorder. And with that, I'll turn it back over to you, Kara. Thanks.
Thank you so much, Zach, and to all the panelists and Mark, our presenter. Very informational, and thank you so much. If you have questions that we did not have time to address today, please email them to our Division of Drug Information email address at druginfo@fda.hhs.gov for assistance. And if you need more CEs for your license renewals this year, please check out our list of home study CE webinars on our homepage, www.fda.gov/DDI webinars. This concludes our activity for today. The FDA appreciates your participation in this webinar. Thank you all for attending, and happy holidays. Stay safe. Thank you.